Can a precision approach to treatment improve sepsis outcomes? Should cryopreserved platelets be considered a suitable alternative to conventional liquid-stored platelets? Are lumbar punctures necessary for febrile infants, ages 28 days or younger? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, December 12th, 2025. I'm Dr. Kirsten Bibbins-Domingo, the editor-in-chief of JAMA and the JAMA Network. Today, I'm delighted to be joined by JAMA Deputy Editor, Dr. Preeti Malani, and JAMA Associate Editor, Dr. Christopher Seymour. Hello, Preeti, and hello, Chris. We have a lot of interesting content for our listeners today.
Hey, Kirsten. Hi, Chris.
Hi, Kirsten. Hello, Preeti. Great to be here.
So we have a lot of interesting content for our listeners today, and we're presenting new content from 3 major meetings. Chris, I'm especially glad you're here to start us off because we're going to talk about featured JAMA publications that were published to coincide with presentations at the Critical Care Reviews Down Under 2025 meeting.
Thanks for having me, Kirsten, and let's get started with the first trial. This is the Immunosep randomized clinical trial authored by Dr. Giamarellos-Borboulis and colleagues. The investigators tested whether a precision immunotherapy treatment strategy compared to usual care could improve outcomes for patients with sepsis, a life-threatening condition due to the host's dysregulated response to infection. Sepsis can be difficult to study because of its heterogeneity, particularly in how the immune system responds to infection, and a one-size-fits-all approach may not be appropriate. In this trial, participants from 6 countries with sepsis from pneumonia or primary bacteremia all received standard care. They also had their host response characterized using immune biomarkers and identified as having either macrophage activation-like syndrome or MAS, or sepsis-induced immunoparalysis. After randomization, the control patients received placebo, while intervention patients received intravenous anakinra for macrophage activation-like syndrome plus the subcutaneous placebo, and those with sepsis-induced immunoparalysis received subcutaneous recombinant human interferon gamma and an intravenous placebo. The primary endpoint was a decrease of mean sequential organ failure assessment score of at least 1.4 points by day 9. The authors concluded that compared with placebo, the immunotherapy strategy improved organ dysfunction by day 9. It was notable the anakinra group had an increase in anemia, and the recombinant human interferon gamma group had an increase in hemorrhage.
Right, so a very interesting trial, and JAMA's senior editor, Dr. Derek Angus, wrote the editorial. And in this editorial, he emphasizes that this trial marks an important point in the war on sepsis, as it demonstrates that at least the trials of precision therapy for sepsis are now a reality.
Next up, we have the CLIP-2 randomized non-inferiority trial. This trial addresses an entirely different scientific question. Most of the world's population has restricted access to platelets for transfusion. This is particularly the case in low and middle income countries, military, or even rural hospitals, and it may limit life-saving platelet transfusions for patients who are bleeding from many causes, such as surgery, trauma, gastrointestinal, or even peripartum complications. So in CLIP-2, Dr. Reed and colleagues investigated cryopreserved platelets versus conventional liquid-stored platelets in the treatment of cardiac surgical bleeding. Cryopreserved platelets use dimethyl sulfoxide to extend their shelf life to 2 years. However, the safety and efficacy evidence have been insufficient for the regulatory approval of this procedure. In the trial, investigators enrolled patients deemed high risk of needing a platelet transfusion according to Australian Cardiac Surgery Platelet Transfusion Score. These patients were randomized to receive Group O cryopreserved platelets or conventional liquid-stored platelets intraoperatively or in the first 24 postoperative hours. The primary outcome was post-surgical chest drain bleeding within the first 24 hours following intensive care unit admission. The authors concluded that the cryopreserved platelets did not meet the predefined threshold for non-inferiority in preventing blood loss at 24 hours postoperatively. They also found that cryopreserved platelets were associated with significantly greater intraoperative and total blood loss, as well as more transfusions of other blood products.
The editorialist, Dr. Neal and colleagues, described the problem of platelet deserts, where supply and storage constraints affect platelet transfusion ability. They note that trials like CLIP2 can help advance knowledge about platelet products and effective substitutes to work toward improving platelet availability for patients.
To wrap up the JAMA Critical Care Review's content, we have the final trial. It's called ACTIVE. In this trial, Dr. Ziniga and colleagues examined the early use of an automated closed-loop ventilation system for critically ill patients receiving invasive mechanical ventilation. Automated closed-loop ventilation can automate the adjustment of ventilator settings, which may improve the adherence to best practices for mechanical ventilation or shorten the time patients are on the ventilator. This trial was conducted at 7 intensive care units in the Netherlands and Switzerland with over 1,500 participants. They enrolled adults less than 1 hour after initiation of invasive ventilation who were expected to receive that ventilation for more than 1 day. Patients received either the automated closed-loop ventilation or a conventional strategy. The primary outcome was the number of ventilator-free days at day 28. And in this trial, the authors concluded that the early initiation of the automated closed-loop ventilation did not increase ventilator-free days at day 28 compared to the conventional protocols.
There's an accompanying editorial by Dr. Sklar and Ferguson, in which they praise the study as one of the largest randomized clinical trials of mechanical ventilation in the ICU. However, they caution that the set it and forget it mechanical ventilation strategy may not be ready just yet.
Thanks for sharing these important critical care studies with us, Chris, and for joining us on this episode.
Preeti, let's move to a younger patient population. JAMA featured multiple trials at this week's Hot Topics in Neonatology conference.
Yes, Dr. Burstein and colleagues evaluated an updated PCARN, or Pediatric Emergency Care Applied Research Network prediction rule for identifying febrile infants 28 days or younger with bacteremia or bacterial meningitis. Most international guidelines for febrile infants presenting with fever in this age group recommend routine lumbar puncture to rule out bacterial meningitis. Now, lumbar punctures are invasive and they can be very stressful for parents. The investigators assessed whether the updated PCARN prediction rule using serum procalcitonin, absolute neutrophil count, and urinalysis results could be used to predict which febrile infants were at lower risk for bacteremia and bacterial meningitis. The authors completed a pooled analysis of 4 published prospective cohort studies from pediatric emergency departments in 6 countries. They included more than 1,500 full-term infants who were previously healthy, non-ill-appearing, with a temperature of 38 degrees Celsius or higher. The researchers used lab values such as negative urinalysis dipstick result, serum procalcitonin less than or equal to 0.5 nanograms per milliliter, and blood absolute neutrophil count less than or equal to 4,000 millimeters cubed to classify an infant as low risk. Using meta-analytic methods, they assessed the diagnostic accuracy of the updated PCARN rule. The authors report the updated PCARN rule has high sensitivity but lower specificity for identifying invasive bacterial infection in this population. They conclude that these results support shared decision-making for select versus routine use of lumbar puncture among infants classified as being at low risk of invasive bacterial infections.
The editorialist, Dr. Cerns and O'Leary, emphasized that the study has the potential for major clinical impact because it characterizes more infants as low risk. However, caution is still required, as missed invasive bacterial infections have devastating consequences for these children.
Patent ductus arteriosus, or PDA, is a common diagnosis among preterm infants and can be associated with complications of prematurity, like bronchopulmonary dysplasia. However, its management is evolving with wide variation in clinical practice, including acetaminophen, ibuprofen or indomethacin, or surgical interventions. Dr. Laan and colleagues conducted the PDA randomized clinical trial. They included infants born at 22 to 28 weeks gestation with a protocol-defined PDA between the age of 48 hours and 21 days at screening. These 482 infants were randomly assigned to receive expectant management or active treatment with acetaminophen, ibuprofen, or indomethacin for PDA closure. The primary outcome was death or bronchopulmonary dysplasia at 36 weeks post-menstrual age. The authors conclude that death or bronchopulmonary dysplasia occurrence did not differ between the expectant management and active treatment groups. However, survival of these infants was higher with expectant management.
The excellent editorial by Dr. Hunscheit and Deboud highlights that the PDA trial adds to the growing evidence that expectant management is safe in the majority of extremely preterm infants.
Dr. Liu and colleagues contributed a randomized clinical trial about optimal oxygen levels for preterm infant resuscitation. The Torpedo 3060 trial compared outcomes of infants born at 23 to 28 weeks gestation resuscitated with an initial fraction of inspired oxygen, or FiO2, of 0.6 versus 0.3. The study was done in 31 maternity hospitals in 6 countries. Infants expected to be delivered between 23 to 28 weeks gestation were randomized before birth. These infants received either an FiO2 of 0.6 or 0.3 during their resuscitation, after which the FiO2 was titrated to meet the standard targets for oxygen saturation. The primary outcome was death and brain injury at 36 weeks corrected gestational age. The authors conclude that initiating FiO2 at 0.6 versus 0.3 does not affect the risk of death or brain injury by 36 weeks corrected gestational age.
Doctors Thomas and Foglia help contextualize this trial in their editorial and emphasize that this is the largest randomized clinical trial to date to evaluate initial oxygen strategies immediately after birth for preterm infants.
Switching gears, there's a trial this week published to coincide with the San Antonio breast cancer meeting about risk-based breast cancer screening. In the Wisdom trial, Dr. Esserman and colleagues examine if risk-based breast cancer screening could be an alternative to annual mammography. This was a multi-center randomized clinical trial that enrolled women aged 40 to 74 years. These women had no prior diagnoses of breast cancer or ductal carcinoma in situ or prophylactic bilateral mastectomy. The participants received a risk assessment that included sequencing of 9 susceptibility genes, polygenic risk score, and the Breast Cancer Surveillance Consortium version 2 model. Each risk-based group, highest, elevated, average, or low risk, received unique screening recommendations. This risk assessment group was compared with annual screening. The primary outcomes for this study were non-inferiority for stage 2B or higher cancers and superiority in reducing biopsy rates. The authors found that risk-based breast cancer screening safely stratifies risk and screening intensity, but does not reduce biopsy rates.
Doctors Baxter and Phillips wrote in their editorial that the Wisdom trial is important because it increases confidence in risk-based breast cancer screening. However, there was low adherence to the screening recommendations in this pragmatic trial, making the effectiveness of such screening uncertain.
Let's turn to JAMA research letters this week. Dr. Scott and colleagues examined trends in vitamin K administration among infants. Routine newborn intramuscular vitamin K prophylaxis has faced public skepticism despite its success in eliminating vitamin K deficiency-related bleeding in newborns. This retrospective cohort study used the Epic Systems Cosmos database, a large U.S.-based electronic health record dataset from 2017 to 2024. The authors conclude that the proportion of newborns who did not receive intramuscular vitamin K increased from about 2.6% to 4.6% during this time frame.
In another JAMA research letter, Dr. Abu Hashem and colleagues investigated the prevalence of metabolic syndrome among U.S. adults using the National Health and Nutrition Examination Survey, the NHANES data from 2013 to 2023. They found that, as of 2023, about one-third of U.S. adults met criteria for metabolic syndrome with no significant change from 2013 to 2023.
A viewpoint by Drs. Agarwal and Norris advocates against banning certain words in healthcare communication. In another viewpoint, Dr. Zahid and colleagues summarize 5 key questions about obesity management addressed in the American Association of Clinical Endocrinology consensus statement and what this means for clinical practice. And there's a JAMA perspective that covers advances in CAR T-cell therapy by Dr. Mahat and colleagues from the U.S. Food and Drug Administration.
The latest JAMA clinical challenge is a 65-year-old with fatigue, nausea, and electrocardiogram abnormalities. Check out your skills. What is the diagnosis? And what would you do next? Thyroid malfunction can be tricky to explain. JAMA has a new patient page on hypothyroidism that would be helpful for clinicians and for patients.
There's also a lot of rapidly developing medical news. Our outstanding JAMA medical news team stays on top of it all and gets you the latest articles in clinical medicine, biomedical research, public health, and health policy. Find it all at jamamedicalnews.com or click on the link in this episode's show notes.
Thanks, Preeti, and thank you for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani, Dr. Chris Seymour, and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.